Hello, everyone, and welcome to today's ASIPP webinar, Comprehensive Physician in Practice Resuscitation Training. At this point, I'd like to pass the floor over to our first speaker, Dr. Laxmaiah Manchikanti. It's now your floor.
Thank you, Michael. Thank you, everyone, all the speakers and attendees. We are getting close to closing down all the stress, hopefully, but new stress may be coming. So today we are going to discuss about quality and value, getting back to normal, prevention of corona in patients, staff and physicians, revenue cycle management, financial reckoning and rehabilitation. We want to thank Boston Scientific for their provision of unrestricted grant and partial funding. I just want to quote this, what Daniel Patrick Monahan said: everyone is entitled to his own opinion, but not his own facts. That has become so common nowadays. Everybody has different opinions, different facts, so he probably is turning in his grave, but nobody listens to him. Now, Trump announced that opening of America again. So what is going to happen to us? This latest survey shows that right now patient volumes are down 65%, mine is down 89%, and will likely remain at that depressed level until the end of this month. They are expected to rebound, but slowly, and will still be down as much as 12% during the same time next year. So this is not going to be a short-term issue. So we are going to have some long-term damage here. Amol is going to talk about that more. At the same time, more than half of patient encounters will be through telemedicine through the foreseeable future. And while that will help some practices in the short term, many doctors are considering furloughing or laying off of their employees. And there is no unemployment option at that time. Supplies and shelter in place have severely limited our ability for in-office visits and procedures. We also get paid less amount with telehealth later on. Right now, they are paying the same as in-person visits. That expires June 6th. We are trying to extend it through August 6th, but either way, everything is going to end, and then we are going to be in normal phase again. If patients' volumes are expected to rebound only slowly, it is not like turning a light switch, like Dr. Fauci was saying. Reaching about 55% of normal in June and 76% of normal in September, that means we are still going to be 25% deficit throughout the year. Along with an unprecedented drop in patient volumes, prescription writing also has dropped. It is expected to be down by a similar percentage in April to reach 80% of normal. Telemedicine is expected to be a big part in the future. Now, the federal regulations set in phases that we can open them. First, then states have their own regulations about opening phase 1, phase 2, phase 3. We have to think about only phase 1 right now. This is what CMS says: testing capacity, what we do for our patients before doing the procedures. All patients must be screened for potential symptoms of COVID-19 prior to entering the NCC facility, and staff must be routinely screened for potential symptoms as noted above. When adequate testing capabilities is established, patients should be screened in laboratory testing before care, and staff working in these facilities should be regularly screened by the tests. Okay, now let us go and look at our great state of Republic of Illinois. It says, preoperative testing for COVID-19. Facilities must test each patient within 72 hours of a scheduled procedure with a preoperative COVID-19 RT-PCR test and ensure COVID-19 negative status. Patients must be self-quarantined until the day of surgery after being tested. And here is Kentucky, phase 2. This is actually a good one. This is going to help us with the risk stratification we developed. All patients must have COVID-19 pre-procedure testing per professional association guidelines, consistent with KDPH guidance. So Shalini is going to present in a few minutes there, but we developed the risk stratification, and it is available everywhere. You can look at it, but that will meet the criteria for your professional association guidelines. Arkansas Department of Health, here we can't help that much. We are trying to write a letter to them and see our friends in Arkansas are suffering. And nobody even knows what all this means. Some of the towns, they don't even know where to go to get testing done. For an asymptomatic patient to be a candidate for a procedure, it is not even surgery, a procedure. He or she must have at least one negative COVID-19 within 48 hours prior to the beginning of the procedure. So this essentially eliminates all the patients unless they are going to change. So that is the reason it is so important and powerful, the risk mitigation. So we will be talking more, Shalini will be talking about this more, and everyone also got just a letter with our revised version a few minutes ago. And Dr. Devi is here today. She will participate in the discussions, and here is the book. Very simple, inexpensive. You can buy and read it. And we had several of these before, and we are also giving 2 credit hours. And next one is on May 5th. It looks like this may be the last one we will be doing. And Senator Bill Cassidy will be here next time, along with Dr. Devi. She will be talking about social media. Okay, Shalini is going to talk about getting back to normal, risk stratification to procedure scheduling and execution. She is the vice chair of anesthesiology and pain program director. I think she spent 100 hours or more in preparing this risk stratification and probably so stressed out now. Shalini?
Hello, thank you everyone. Thank you, Dr. Manchikanti. So last time we were on the webinar last week, we spoke about the risk stratification methodology. And today I want to go over the revised methodology, very slightly revised, but importantly revised methodology, and then go over a step-by-step workflow process. For those of us who bring patients into an ASC, what are the considerations we should have? Do we do general? Do we do MAC? Does it make a difference? Those type of workflow issues, and how to create important policies within your practice. So as you know, CMS as well as the Trump's government has, as we've said many times, is talking about opening up again, and this is really state specific. But one of the things I want to stress is that CMS recognizes that there are times, or there are states right now that have a very low or relatively low stable incidence of COVID, okay? And that policies that may fit New York or high impact areas may not be appropriate for other states that have not had a COVID impact, such as South Dakota or North Dakota, for example. And that it's important to be flexible and allow facilities to provide care for patients who need non-emergent, non-COVID-19 health care. And that's one of the reasons why we updated our methodology ever so slightly, but very importantly, like I mentioned, about risk stratification. Because we recognize that local geographic variances occur, and individual state department, public health departments have their own requirements of what is needed for testing prior to bringing your patient in, whether it's to an ASC or for a procedure. So as you can see, this is the updated risk stratification. And this is a really important step to take because it's important to be thoughtful in the way we bring patients back. I want to reiterate this is important for phase 1. As we go from completely closed doors to opening back up again and the amount of apprehension that exists with that, it's important to be strategic and thoughtful of how we do it. Because we, as you know, as I know, we may have a resurgence in the next few months. So this is the updated guidelines, and I want to stress some important changes. Number one is that if a patient resides in a nursing home, that is an independent risk factor, and that has not changed from the previous recommendations. If your patient has been in a nursing home or incarcerated or an assisted living facility in the past 30 days, consider this patient high risk, and we'll talk about what that means in the next slide. So age was considered an independent risk factor. However, with further evidence that has come through, we have recognized that age can be stratified into low, moderate, and high risk. So those in the low risk group are those between the ages of 45 and 64, and those in the high risk are 75 plus. The other patient comorbidities have not changed. So if your patient has moderate to severe asthma or COPD, you are still going to consider them high risk. And a scoring tool exists below, so those patients with a score of 15 or more are considered high risk. I want to stress the importance of this, of using patient comorbidities as the first step. I see a lot of practices, and not just in pain management, but for example, GI labs or the ORs who open up for elective surgeries and are not considering patient factors when we open up. And I think this is, like I said before, a really thoughtful, really meaningful way to risk stratify your patients to mitigate the risk. So this is the updated flow chart. Now you've risk stratified your patients, and we recommend that you risk stratify them 24 to 42 hours prior to the procedure. And I want to state some important changes on this. Number one is that this is a toolkit. These documents are not meant to be standard of care, and we clearly label that on the documents. And it's very important to stress that physician discretion above all takes place. Right, so there are some patients that would fall into the high-risk category. For example, a 75-year-old patient who comes in for trigger point injections. Would you delay it? Probably not. That's where physician discretion and physician risk-benefit analysis is important. And we make that very clear in the disclaimer, and we make that very clear, I hope, to you through this flow chart as well, that it's ultimately up to the physician and the disclosure that you have with the patient. So again, if you know your patient's COVID status, yes, and they've recovered with or without serology testing, you can be pretty confident to proceed with the procedure. However, in those patients in which the COVID status is unknown and they are symptomatic in the last 14 days, without any discussion, you and we all know we're going to refer the patient for COVID testing, and if it's positive, self-quarantine. But about what do we do for those patients, about 75 or 80% of our patients that are asymptomatic and we don't know the COVID status, and this is the bulk of those patients that are going to be walking into our offices. As you just saw on the previous slide, we have risk stratified them either into the low, moderate, or high risk. If your patient scored low, you can proceed rather safely with or without steroids, or if you do elect to use steroids, you may want to use lowest therapeutic effective steroid dose. The moderate risk patients really require that risk-benefit analysis in your clinical judgment. And we balance that against the patient's severity of pain. Those patients who are suffering, who have very limited functionality because of pain, it may make sense in those patients to proceed with the procedure, given that you improve their functionality and their quality of life, and that there may be some other patients where you say, hey, we can delay these procedures, let's get some testing done. For the high-risk category at this point, and I'm going to stress again that this is phase one. We do intend to liberalize the recommendations, but for phase one, as we just opened, we do recommend for the high-risk patients to delay the procedure. I would say it's prudent at this time to have your patient undergo a little bit more COVID testing per the CDC guidelines or serology testing, depending on what your state recommends or what the CDC recommends, depending what takes precedence, your state or your national guidelines. But at this time, we would like to err on the side of conservative management. As we just open up our practices, and those high-risk patients, we would recommend that you delay the procedure for further testing. Again, physician judgment and risk-benefit analysis is going to be paramount here. This is our risk disclosure document, and this is going to be also included in the toolkit. You have received the documents through email, and you can download these documents on the website as well. This is a great way for you to have a discussion with your patient about risk, about COVID. Okay, as we embark on procedures, patients will have a lot of questions, and this document pretty much allows you to have a conversation, or at least find the terminology or the wording that you can use to have that discussion with patients in their best interest of the risk, benefits, and alternatives. So this is going to be a really great document for you to use. You can put your logo on it, put your practice name on it. It's on a Word document, modify as you need for your use. What about workflow? So as we consider going back to work, there's a process flow that needs to be imagined, okay? The first step, as we talked about, is the risk stratification. That document that we talked about going over the patient's comorbidities, 24 to 72 hours pre-op. Interestingly, I've gotten a lot of feedback. Some institutions are considering actually implementing that risk stratification calculator into their EMR, leveraging their EMR so that it doesn't take up nursing or MA time. It's a quick calculator to do, and use it through Epic or Cerner or whichever EMR you use. So that's something that can be done. The second thing you're going to do as you risk stratify your patient is really have a frank discussion about the need for sedation. Since you have the patient in front of you pre-op a day or two before, you may want to have this discussion. Do you think you can do this without sedation? And we'll talk about why that might be important. You're going to talk about pre-op COVID testing, and that's, again, based on your state or regional guidelines, whatever your State Department of Public Health recommends. Another process to consider is screening. Most facilities currently are screening staff. As you walk through the entry and exit points, staff are screened for temperature amongst other symptomology. But what about patients? Not all health facilities are screening patients, and you may want to incorporate that in your facility at the entrance to the facility, not when they get up to the office. Patient protective equipment. This is important because we talk about physician protective equipment, but there's also patient protective equipment. It means how do we protect the patient from the staff? So that's going to be important to talk about. Waiting room organization. Remember social distancing. You want to keep your waiting room so that everyone is about 6 feet apart and have regular times for clean down, where staff can come in and wipe everything down. You want to limit the amount of visitors and drivers, and perhaps have a discussion about keeping the drivers downstairs in the car until they're ready to pick up the patients from your ASC or procedure suite. We're going to talk about prep and positioning the patients. And then the most important elephant in the room is, how do we sedate these patients? Do we sedate them? We're bringing them into the ASC. Do we go without sedation? What are the risks of sedation? So one of the things that I recommend is that all patients and staff are masked, and this is should be a mandate at your facility if it isn't already. But the question is, if we provide sedation, IV sedation, can you deliver oxygen through the mask? And the answer is yes. You can still deliver nasal cannula. But what about those patients who undergo anesthesia? So in the case of IV sedation, most ASCs still recommend physicians wearing N90 and staff wearing N95 masks during phase 1. But however, if your patient does not require IV sedatives, there is no recommendation at this time to use N95 masks. A regular face mask should be fine. There's also the consideration of PACU and throughput. So those patients who require IV sedation will require PACU time, and that will delay your throughput. So the more time the patient spends in the facility, the potentially longer time there is for exposure. So that might be another consideration of why to limit sedation and having that discussion pre-op with your patients. And there's also finally the discussion for those of you who operate in ASC, OR turnover time for general cases. So these are some of the policies that you may want to consider for your practice to create prior to returning to work. Number one is a screening policy, screening patients and visitors at the door. Managing your entry and exit points, having a flow through that doesn't require the patients who are entering the facility to also be exiting the facility at the same point. ASC OR turnover, and we'll talk about that, about how long we should wait between turnover, between cases. Limiting visitors and drivers in the office. That's another policy that you may want to create. And then physical distancing policies. And this will really be important to not only showcase to your staff that you care about your staff, but also showcase to your patients that you're really considering their health throughout this process. And not to mention your state guidelines as well. So one of the questions that typically comes up is, as we open up for phase 1, we don't know who has the virus and who doesn't. is there an optimal time for patients or for us to turn over our rooms? And this really depends on how your ASC is set up and the air changes per hour that your facility has. So you can click on this link and the CDC table will come up. Depending on your operating room setup, typical operating rooms have 15 air changes per hour. And if you look at that chart, you can see that about 99% of the airborne pathogens will be removed from the operating room in 18 minutes. So this is really important. You can safely re-enter your operating room in about 18 to 20 minutes without an N95 if your patient was known not to have COVID, or with an N95 if the status was unknown. Okay, so it depends on your air changes per hour set up in your ASC or your OR. What about MAC cases with an open airway? So the question always comes up, if I use IV sedatives and I use a MAC for my pain procedures, how do I protect the patient? How do I protect myself? First of all staff should be wearing an N95 in that case. And for the patient, you may want to continue masking. Whether an N95 is needed or not, it's up to you. But also you can deliver oxygen nasal cannula through the mask. As a follow-up question, how do I deliver supplemental oxygen to the patient? Again, nasal prongs under the surgical mask is simply fine, and that should suffice. And that's it. We will open it up to questions at the end. Thank you. I'll turn it back over to Dr. Manchikanti.
Thank you, Shalini. That was great. The document we are submitting is risk disclosure rather than consent. So other issue is N95s are not available. That will be extremely hard to go through them. Other indication is that some of the states are making it mandatory that we use surgical masks in all ASCs. You can, outside, if you are just treating the patients with follow-up visits, initial evaluations, etc., you can do the cloth masks. So that is what we are offering, and it is states are saying that we have to offer the patient and the attendant a mask. So having said that, looks like Harold is here. Harold, are you here? Harold?
I am here.
Oh, okay, good. Thank you. So we have been very eagerly waiting for your lecture here. Harold is the president of ASIPP, and he just took over in probably a month ago. No, not even quite a month. So he will be speaking about quality and value about ASIPP is providing to the membership. Here we go. Harold?
Well, thank you, Lax, and good evening, everybody. So today we're going to talk about quality and value, and I'm going to kind of speak from my heart as a loyal ASIPP member and as someone who's been able to accomplish a lot and use ASIPP. So let's take a look first at ASIPP's top 10 achievements. So we'll go over these kind of quickly, but I think of ASIPP as certainly the premier pain management organization in the world, probably, and what it's done for members is really tremendous. And we look at the value of what ASIPP has done, let alone the quality of the work. We'll go over some of these, just kind of some of the value things that we've gotten. Certainly, we have introduced interventional pain medicine as the specialty on the Carrier Advisory Committee. That was certainly Lax's baby early on. That got us representation on Medicare, enabled us to put input into getting things like facet joints and kyphoplasties and vertebral augmentation not taken away as a covered procedure. We still fight that. Facet joints are coming up again for a nationwide evaluation on what they're going to cover. So it's very important that we have those people on each state committee. We've had a pain physician journal and pain medicine case report. So we have two journals that are excellent and very highly regarded in the impact factors are like 3.7 was the highest one, and that's tremendous as far as quality of a journal. No other organizations in pain really have as good a quality of journal and as well written and looked into. NASPR, everyone knows about NASPR. That was a very big effort to get prescription drug reporting, and we all use that on a daily basis now. Years ago, that was just a thought, but we were the first ones on that. Specialty designation for interventional pain management, basically increased our practice expenses from $59, which was anesthesia or pain management, to $156 for interventional pain management. So that's huge as far as what you get reimbursed on a daily basis for the things. And that, again, was solely on the ASIPP's shoulders to get that interventional pain management designation. Physician payments, every year we fight that as far as, I don't know who keeps switching that, it decreases. We have fought decreases in reimbursement, and pain management has been one of the few specialties that has done well as far as keeping our reimbursements. SGR, FDA, all that other thing. So we'll go over these kind of quickly. I don't want to waste too much time on these. So if you just look at the ASIPP website, just the resources alone that are on there has value. So if you look at, just go to the website and just look at the information that's on there. You have the Pain Physician Journal. You can access that through the website. That's a free access journal. It's pretty hard for any journals now to be free access, and we talked about how well regarded that is. You also have the Pain Medicine Case Reports. That's a new journal that goes through case reports, and if you're interested in publishing, either of those two journals are published very regularly, and you can fairly easily get good publication data in there, and you can access those for free. We also have the Specialty Board Certification in Interventional Pain Management, which is now accepted in most of the states around the United States, so you can declare yourself as board certified. And there's both a written as well as a practical exam, and it's really the only board examination recognized that has a practical exam. That goes back to the Carrier Advisory Committee. And that's the ABIP. Those are the state medical boards that do recognize the ABIP as a board certification. The NorCal, this is a good value. So NorCal is a malpractice insurance carrier that has agreed to give big discounts to ASIPP members. They'll also cover you if you're doing clinical trials or research, which is difficult. And we have a 20 to 25% savings for all ASIPP members, as well as a discount if you're ABIP certified. Henry Schein, this is huge. All of you that use contrast is very expensive. And if you purchase contrast alone, just through Henry Schein, we have a good purchasing organization. It's about $4.50 for a 50 ml vial. It's at least 10 times that amount if you're going to buy it outside of the purchasing organization. That alone is going to more than pay for your membership to ASIPP for 1 year. I use that, and it is a fantastic resource. So I highly recommend getting involved in that purchasing organization to ASIPP. Fedora Billing and Revenue Cycle Management, we have partnered with them, and they are charging 3% for billing and revenue management. So 3% for billing and revenue management, especially in someone that specializes in pain management, is tremendous. So if you're looking for a good quality billing company or someone that specializes in pain management, you're unhappy, certainly look to them. And then let's go over the next thing. So let's just look at the COVID response and what ASIPP just in the past couple of months has done as far as this. It's really tremendous. We have given a lot of research and a lot of advice onto the HHS payment program. We've announced that early. ASIPP was also very fundamentally involved with getting those payments to the physicians. We were instrumental in going to Congress and getting, so all of you guys that got paid tens, if not $100,000, that's very much due to Lax and ASIPP getting that done. We were responsible also for getting the telehealth extension. So those of you that are doing telehealth will be able to do that for a longer period of time past your phase 1. Putting pressure on telehealth for Medicare Advantage plans and commercial payers. So not only those Medicare patients, but those accelerated Medicare payments, we were able to get that done and extend the time that you have to pay it back. We've had these weekly webinars, which have been tremendous. We have this breaking news that we send out almost on a daily basis, business economic information, the ASIPP updates, and back to work procedure guidelines. So all these things have been done by the ASIPP organization for you, and these have been tremendous assets for you guys for as far as value and quality. So those are the breaking news. They come almost every day. These are some of the HHS letters that we see that ASIPP wrote to Congress and HHS. The same there. And so again, on the website, if you look at, there's your COVID resources, there's the breaking news, there's your webinar series, which you can go and look at them if you missed them and go and they've been recorded. There's business and economic information there, practice information, and further updates every day. So from a perspective of looking at what ASIPP does and what it's accomplished and does it bring value and quality, I think that's pretty obvious at this point. So high value and high quality, I think ASIPP hits the mark there, and I hope you all take advantage of some of the things that we've given you as far as the values and things, and realize how valuable ASIPP is compared to other organizations or even not joining at all. So again, thank you for joining the webinar. Thank you for being part of ASIPP. And thank you all of the membership and leadership in ASIPP for all you do.
Thank you, Harold. That was great. You spoke like Leah Iacocca. Look at everything. If there is quality, buy it. If you don't, look at other things and go and buy them. So that was good. Thank you. Now we have Amit Mahajan. He's going to speak about prevention of corona in patients, staff, and physicians. You heard him before. He's an interventional radiologist, also has infectious diseases. He's assistant professor of radiology and biomedical imaging at Yale University. Amit?
All right. Good evening, everyone. This is Amit. I've spoken here before, and thanks for the invite to talk to you guys again. So my topic is on prevention of coronavirus in patients, staff, and physicians. And we're going to go through our slides. So just to, this is going to be a little bit off what you guys are talking about as ASIPP. So this is more from an infection control point of view. So which I guess you can listen to this part and that part and try and make some sense of it and come up with a consensus way of dealing with patients. So CDC has come up along with FEMA with these guidelines called phase 1, 2, and 3, in which I could not find on the CDC website, but they seem to be all on Washington Post and their website and the other news items. So I don't know whether this has not been approved by Trump and but has been floated by CDC as guidelines, which they may be using it in the future. So their plan was a phase 1 in which they were to prepare the nation by May 1st, and then a phase 2 of innovation and by ramping up the manufacturing of test kits and PPE, and also increase emergency funding by May 15th. And then a staged reopening, which will be basically based upon community impact. And So the certain conditions had to be met before they reopen. So the couple of things which have to be thought about are the incidence of infection has to be genuinely low. There should be a well-functioning monitoring system for prompt detection of increased infection incidence so that the public health system can react to it. Also, the public health system should have the surge capacity to react to an increase in cases. That should be available before you try and open up everything. And finally, health system should have enough beds and staffing in case things were to go bad to go back to square one where we started from. So those conditions have to be there before they move on to the further stages of opening. And based upon that, they've divided the community mitigation categories into three different types. One is the low mitigation area, which is basically low incidence areas of the country, which can potentially reopen faster, as compared to moderate mitigation. Moderate mitigation basically is defined as former hotspots which are entering controlled recovery. Also, in this situation, they feel that contact tracing will be very essential, and that basically contact tracing is the big thing which they're pushing for, and they have already allocated $25 billion to doing more tests and getting all these people traced. And finally, the third category is the community with the significant epidemic still going on, and these are current or emerging hotspots. And things can move from one category to the other. And so significant mitigation will also include moderate mitigation community, which have showing strained capacities. And these things will remain, will have shelter in place until the previously mentioned thresholds are met. So what are the staged approach to reopening, which they have come up with is first of all, they want to open up is childcare settings and schools and summer camps so that people, there is enough childcare so that the people can go back to work. After that, things like restaurants and bars, general workplaces, social gatherings, and then high-risk facilities, and finally colleges and universities. And California has come up with their, Gavin Newsom has come up with this 4-stage plan. The first stage was when they had everyone stay at home. Stage 2 was lifting restrictions on low-risk workplaces like manufacturing and other things. And stage 3, which he thinks is months away, is after they have enough testing, is when it's hard to read here. This includes personal care businesses like gyms, spas, and salons. Although we know that Georgia has moved faster on this in this group and has already opened up those areas. And then also things which are included here, sports facilities without live crowds, and then in-person religious services and businesses with close contacts with customers. So those are months away from now in California. And finally, the stage 4 is end of stay-at-home order, and this is once the therapeutics have been developed. And this is when he thinks he'll open up the concerts and convention centers and sports with live crowds. So that is kind of his last stage to open. And this is based upon the abilities which have to be established before opening is expanding testing and isolating patients, protecting seniors and high-risk people, ability to meet future surges by getting enough protective gear, availability of therapy and treatment, ensure continued physical distancing, and an ability to pull back and reinstate in stay-at-home orders if required. So how does this fit in with you all doing pain procedures? So the couple of things which I think which we need to remember is, one, that going out into the community and doing procedures, you have to consider every surface, procedure, environment is potentially infective. And also remember that whenever you start doing procedures, also consider that any of these contacts may turn out to be ill in the next 14 days. I have colleagues in my place who have turned out ill in the last 2 weeks. And so, I mean, there are implications to working together, and things are going to happen as we go into the future. And in this context, it's good to remember that we have to be safe for ourselves and our staff, as well as safe for our patients. And so the way to whatever I can think of is the way to handle this would be, first of all, to have a good patient assessment, especially when we're doing pain procedures. One is get a history of recent illness, exposure in the family, friends, or co-workers. Consider serology testing. If someone is positive, then they're potentially immune. We still need more data on this going forwards, but at least we can think about it. And if they are negative, then obviously we have to proceed with caution, because these are non-immunized or non-immune people. And remember that in California, there only 2 to 3% were positive on serology, so that means the other 97% are not. So we have to be careful going forward. And this is another chart showing you how to deal with this. So if someone has had an infection, and this is the green bar, we can proceed with the procedure. If someone has not had an infection, then potentially, if they are symptomatic, then it's obvious we do the PCR testing. This is the red bar. And then if they've never had symptoms and never had the infection in the past and they're asymptomatic, so the one other way of doing it is to look at serologies. If they are positive, we consider them immune, we proceed. But on the big group of people is this, in which the serology is negative, and our hospital is checking PCR at least 48 hours before doing any procedure in the hospital. So you can consider doing a PCR at that point as well, before doing the risk-benefit assessment. And as far as safety for the patients, the two things: one is the safety from acquiring a new infection, which is going to come from us or people who are working with us, and the other thing is safety from steroids, which I guess you guys are already working with the risk assessment tool on that end. And so most things, safety from acquiring new infections will come from infection control procedures in the procedure room or office, use of mask or PPE, and obviously no hand shaking. As for ourselves, we are going to use the same things that we talked about before: mask, gloves, gowns, face shields, also shoe covers. They still found virus on the floors as well in their study in China. And so it'll be a good idea to put on shoe cover, especially if you're coming back home and not taking off the shoes. So I think it's important to leave the shoes behind in the garage. And finally, we're going to continue hand hygiene, cleaning up our work areas, and doing procedures, clean lead and cover it with the disposable gown. I think we went over these before. Getting out, have a plan, use removable clothing, protective material, avoid touching skin, face, and surfaces. And protecting, a couple of things about protecting staff is, of course, everyone's gonna wear a mask, and this is especially when we're going to open our offices. Wear a mask and use shielded areas when where at the entrance or where there is contact with the patient. Distancing the waiting rooms, as Shalini mentioned, will also be important. Also cleaning up the desktops, phones, computers, etc., and credit card readers and everything else. Hand hygiene, and also make staff aware to notify us in case they're sick or unwell. And in the interventional suite, minimize number of staff involved. Maybe just have one more tech and a runner who can go out and get the medications. Get all the medication and procedure-related equipment together prior to the patient entry into the room. Use PPE. There are specific things about donning and doffing areas. Also, some suggest using a buddy approach in which you are doing it along with someone so that they can point out if there's a infection control measure that you did not follow. And finally, use plastic sheets over all the equipment. Good graphic about different parts where the patient, medical staff, and environment are. We're going to keep our environment covered and clean. On the medical staff, we're going to put a full gown and a face shield and cover the part of the gown with the glove. And for the patient, using a surgical mask is also important. Most of the radiology areas who are doing plain films and other CTs are usually using a normal surgical mask for patients, and they are supposed to keep it on during the procedure. And as far as what is the correct mask, there is no difference between different kinds of masks. So between the N95, there is level 2, 3, level 1, and unrated masks. So most cloth masks are the unrated masks. And this is for staff in non-patient care areas and patients and visitors. So level 1, 2, and 3 are basically a higher level of fluid resistance. The level 1 is good to avoid droplet precautions, while level 2 and 3 are used to be used in the OR and high splash risk procedure areas only. While N95 mask has the maximum filtration and it's used in COVID isolation and aerosol generating procedures. Last few slides is finally, when we come back home, we're going to follow the decontamination protocol, use disposable clothes which can be left in the garage or car, use clean contaminated areas, separate out the clean area from the contaminated area so that you have a better handle of what's happening, and have a bath of cleaning up after coming back from work, wash arms and face. So in summary, we know that COVID-19 is infectious. It can be spread through asymptomatic carriers. We should be able to minimize risks by using social distancing, which we are doing. Also mindfulness, planning, and using precautionary measures at home and at work. And with these final things is physical distancing, continuing that with the 6 feet distance, avoiding handshakes, frequent hand cleaning, masks, we should be able to control the spread of infection. And this is a good cartoon showing how someone is trying to avoid contact with patient using a whole polythene around it. We laugh at this image saying that this is extreme, but there are people who are using this to intubate patients in the ICUs right now. I think that is the last of my slides.
Thank you, Amit. It is great. A lot of these things you are talking about are a little bit different in our interventional pain management practices and ASCs. For example, we can't get any of these masks, so we are just improvising. We are using surgical masks, as many as available. The next thing is that we always have a registered nurse in the operating room, and then there is a radiation technologist, radiological technologist. Then we also have a surgical technologist sometimes. So there is minimum 3 people there. So that theory about 2 people may not work in a lot of our settings. I just wanted to point out because interventional radiology is a little bit different type of a practice. Okay, thank you. Now we have exciting things about revenue cycle management. Everybody's trying to look at it, but there is no revenue at this time. So once it comes in, we have to manage it properly. Ian is CEO of Anesthesia Dynamics. He's going to speak on about revenue cycle management. You heard him last time about independent physician association forming one. We are looking into it, and today he will speak on revenue cycle management. Ian?
Thank you, Doctor. Hi, my name is Ian Myers. Everyone, thank you very much for giving me your time and attention. Greatly appreciated. I hope that the few minutes I have here is to give you some tools that you can use that won't take you much time in order to keep a good pulse on what's happening with your cash flow and the performance of your revenue cycle. And hopefully also give you some tools.
Your slides, Ian. Sure. Slides are not moving. So.
Oh, there we go. Thank you, Doc.
Okay, now you go.
So hopefully what you can walk away with are a few tools that will allow you to keep track of what's happening with your revenue cycle management. Many of you may already have these or are very familiar with it. And for those that haven't, hopefully these are some little tools that you can use to expedite your review of what's happening with your revenue cycle. And hopefully we can also give you some advice during these challenging times that will help you find some money, but also increase some of your revenue on a per procedure basis. So I really wanted to focus in on 3 primary key performance indicators or KPIs One of these is days in AR. And this is an unprecedented time. It's difficult to see what's happening at the insurance companies right now, how much is really happening with the claims that you're submitting, how fast or how slow are the processing of those claims taking place, what other delays inside those organizations are impacting how fast you'll get paid, how accurately you'll get paid. So one of the things to watch is what we call days in AR. And really this is the turnaround time, or what we call TAT, the time that you submit the claim to the insurance company to the time that you receive payment. And this is an old formula. It's been used for years and years, but it's effective if you use it appropriately. And the formula is this. It's gross accounts receivable divided by the average monthly charges multiplied by 30. Now, average monthly charges is something that you would have to determine what best works for your practice. I would keep the denominator small here in determining what your average monthly charges are, because most of you are going to be climbing up a hill as you start to open up your practices again. And so the average monthly charges are going to be small to start and grow and grow. So keeping 2 months as an average or 3 months is probably going to be most effective. But really be familiar with how an insurance company is contracted with you to perform and set expectations based upon that. So simple questions are, how are your claims submitted? If they're sent through electronic data interchange via electronic claim submission, maybe you set this as 1 day to get to the insurance. Maybe it's 2 days. We typically use 2 days. In this time in the crisis, we've seen it go to 3 days and 4 days. If you're sending paper, try to find a way to go to electronic, because what we are finding is that anything submitted paper is not being processed, because there's nobody on the other side to scan that and get it to a party, which a lot of insurance companies use Indian outsourcing units to process right now. It has to get to an electronic format. So if you're sending paper in, you should expect large delays. If you're sending medical records in, if you're sending in paper claims, expect a very long delay. I have 5 days here, but that's not during the time of pandemic, and that's accounting for postal time. We know postal time has gone to 10 days and even 15 days. So keep this in mind as you look at your revenue cycle. Are you in network or are you out of network? If you're in network, use the contract time frame that you have in that contract. If you're out of network, expect long delays. The insurance companies, whether it's intentional or not, are delaying how things are getting processed. How do you receive payment? Are you getting payment via electronic funds? If you're not, get it set up as fast as you can. CAQH is a great organization to get this set up and work with your insurers. If you're getting paid on paper, you should expect delay, whether it be from the postal system or just the people at the insurance companies that are actually stuffing the check into an envelope and sending it out the door. They may not be there right now, and they may not be there for months. What is the average co-insurance? This is something typically, historically, you can look at and find. And you just add up those days, and that gives you kind of a benchmark of what to expect. A few different collection rates to look at, or a couple. Gross collection rate, this is your gross payments of your gross charges. I think most people are familiar with that. More importantly to look at is the net collection rate. This is the gross payments you receive over the sum of the gross payments and gross adjustments. This would be what you should receive as far as an allowable from your insurance company. And what is the contract fee schedule in comparison to your pricing structure then? Comparing those two tells you how far you may be off or on the mark. And then include what we'll call your bad debt. This would be your traditional accepted amount that you would write off on a regular basis, whether it be monthly or annually. Most of your accountants can provide you with that number. And then the third KPI to consider is your AR delinquency rate. This would be if you said, what is your expectation as far as when a claim should be resolved? mark, maybe that's 90 days for you. Anything over that age, divided by your gross AR, that gives you a percentage of what is my expectation, and am I over it, am I under it? Your billing folks or your billing company should be able to quantify, the difference above what your expectation is. And I'll come back to collection rate in a minute. One of the things that I think everybody should really take the time, that they have available to act upon is your contracted fee schedules that you have. This is an unprecedented time. There's a lot of opportunity for force majeure. There is a lot of additional costs that you guys are taking on right now for labor to sterilize these various surfaces, the additional PPE that you're having to use, the masks. There's a tremendous amount of cost that you're taking on to do your normal course of business. This is a time to reach out to the insurance and tell them that you have to have an additional amount of money considering the crisis. We have a standard that's been set by Medicare of 15%. This is something that you should reach out to your insurer and do this electronically if possible. I know I have it certified mail, which is always good to do, but electronically is the way that you're going to get a response, I think, at this point, whether that be via email or via fax, but have some proof that you've delivered it. But this is the time to reach out and say, I need more money, and this is my request or this is my ask, and engage that conversation with the insurers. But when you do this, make sure that you have a very good detailed list of what your fee schedule is that you believe with the insurance companies, and they frequently change this or send notices that are hard to catch. So it's important that you take the time to list out every CPT code you have and the modifier combinations, the various places of service that you operate at, the various provider types that you use, as well as any other items such as bundling or multiple procedure reductions. Take time to send a very detailed chart, send it in, demand your increase, and use Medicare as a basis, but also detail out all the additional costs that you're taking on. And I know I'm running out of time here, so I'm going to skip pretty quickly through this, but this is a tool that we frequently use to monitor and track the insurers. It brings together all those KPIs. We call it a roll forward. It takes the data from each month, and you add the next month and so on as you go through time to track the performance of your revenue cycle. You have your AR goal on the left-hand side there, and then versus your actual days. This is a practice, it's a sample that started in January, so there's not a lot of data there, but it gives you an idea of how you're climbing up. So compare those two, AR goal to AR days, and also to the right, you'll see there's the collection rates to compare. What ultimately you should see happen through time is that your net collection rate, your gross collection rate should be coming very, very close together. And, ultimately that would identify that you're being paid according to your contract. And that's an important thing to watch as far as if the needle swings lower or higher, that indicates that something's going wrong. So this is a report that takes maybe an hour to go over each month, but it's really going to give you a pulse for your practice. Lastly, I just want to point out that, audit. Keep auditing your internal operations. If you're doing billing internally, do it at least once a quarter and have an outside party do it. These usually return, ROI on these is at least 200, 300%. There's usually money that's found, especially if you involve a certified coder to be reviewing the entire chart. If you're using an outside billing company, take the time to request them to do it. This is something that they should be doing on a regular basis, and those audits should be made available to you as far as issues that are being found in your accounts receivable. There's a lot of good auditors that are out there, but at least change it up. Don't use the same auditor all the time. Perhaps one quarter use one auditor, the next quarter use a different auditor, but at least audit every quarter, because especially in these changing times, there's going to be opportunities there that policies have changed, reimbursement rates have changed because of COVID, and you're going to want to grab every dollar you can to climb out of this hole that COVID has created. So with that, I know I'm out of time, Doctor. So thank you everybody for this opportunity.
That was great. You gave a different perspective than what we had other day with Maharshi. He was great, but different perspective. So it does very well. Now, the next speaker is Amol Soin. You know him very well. He's the president-elect of ASIPP. He sleeps only 3 hours each night and none during daytime with a small baby. So he's going to talk about financial reckoning and rehabilitation, fact versus fiction. Amol?
Yes, thank you. Hello, everyone, and good evening, and thank you for the time today. I'm going to be talking about financial reckoning, fact versus fiction, and some survival tips that we have. I put a date on this slide deck here of April 28th because I just know that things are changing and evolving so rapidly. Like I have with other these talks, I mean, obviously, ultimately, you guys are responsible. These are just my opinions, and it's always good to consult a lawyer, a banker, or an accountant. So let's provide some updates that are pertinent to right now today, starting with the Medicare advance payments. That program was suspended on April 27th, and that's unfortunate. But basically, they had approximately $1 billion budgeted of what they wanted to give out, and that had been sent out, and it triggered this alarm to suspend the payment. So if you haven't applied already, or you haven't even gotten your money, or you haven't started the process, I probably wouldn't spend too much time on it because it doesn't look like that's coming anymore. Some of the MACs were faster than processing than others. So, for example, in Ohio, where I'm in, they did a really good job of processing applications anywhere from 3 to 5 business days. As you know, if you did get this money, that this money must be repaid 120 days after you receive the money. ASIPP is working hard to try to increase that day amount to 180 days, and also to make it so that all 100% of your claim is not used to repay, that is decreased to 50%. So we'll see if that actually happens, because the way it works is when you start getting your seeing Medicare patients again and you start collecting that money, basically when you get your EFT, Medicare is going to deduct from that to pay back your loan. But it is an interest-free bridge loan, and that is obviously a good opportunity for those who took it. Let's talk about the HHS stimulus, and you've seen this in breaking news from ASIPP, that we had a first round of money that came that was about $30 billion, and they used a formula of about 6.1% of the previous year Medicare billing, and you got that basically as a grant that was an electronic fund transfer into your accounts. There's a second round of money that's $20 billion, so approximately, 2/3 of what the last stimulus was. However, when the first one went out, just like the PPP loans and other things, there was an outcry in the media, and people were upset, saying, "Hey, why did you give everyone the same amount?" Some people are hit harder than others. Some people are in rural areas where they haven't even seen a coronavirus case, but you gave them all this money, and other areas have really been impacted. So that doesn't seem fair. So in the second round, the HHS has tried to create a system of fairness and transparency with some self-attestations. The money has, what I heard, actually started to go out earlier this week, although I haven't known anyone that's gotten it. I did hear a big bolus will be going out Friday at about 10 a.m., but basically, in order to even get the money, you have to go to this website, hhs.gov, and then the Coronavirus CARES Act Provider Relief Fund section. If you can see the website link here, but I see several people are on the phone, so if you just Google Coronavirus CARES Act Provider Relief Fund HHS or something in that nature, you're going to end up at that link at the top of your Google search. You have to click the general distribution portal and then log in to complete some attestations. In the attestations, you have to provide your gross receipts or sales or program service revenue, and that's as submitted on your federal income tax return. And when you have your federal income tax return, like your 1040 or whatever form you use, depending on your corporate structure, it's usually that first line item on there. Actually, I did this. The whole process, if you have everything you need, which are your tax returns, your Medicare number, your bank account number, your tax ID for your clinic, as well as the dollar amount that you got in the first stimulus, as long as you have those 4 things, this will literally take you 5 minutes to complete the attestation. Secondly, what's actually really important is you have to provide estimated revenue losses in March 2020 and April 2020. And that's going to be used as a formula to calculate the amount of stimulus money you get. Keep in mind, these are estimated losses. And keep in mind, what they're not talking about is gross collections in March, right? Because your gross collections will probably be higher normal because the way billing trails 4 to 6 weeks back, what you actually collect in gross collections in March actually depends on what you did in February, likely prior to the pandemic. So you have to estimate the amount of claims that went down, the number of claims that you've lost, or the percentage decrease in patient flow that you saw in March or April, and try and use that to calculate estimated revenue loss. And keep in mind, it's just an estimation. So if you're a small practice, or even a multi-group practice, you're not like a hospital or a major network. I don't know how granular they're going to get with estimations, because even if you're off by 10%, it's only, a small amount of money. Of course, if you work for a large academic center or large hospital institution, they're going to have very significant losses in March and April. There's a hospital in Dayton, Ohio, and we're not a huge city, Dayton, Ohio, that had estimated the revenue loss for March and April to be $35 million. And I could imagine if your numbers are that high, you're really going to have to prove it or justify it. But if it's a smaller amount, I'm not sure it's going to make all that much of a difference. And you also have to have a copy of your most recently filed federal income tax return for your company, and a listing of the tax IDs for any of the organizations that you're using. The second thing to tell you and remind you is that you have to attest for the first round of HHS money, and that is different than what I just mentioned. So if you haven't actually gone in and done what I just said and gone to that website, after you get off the phone today, please do that. And the reason why is they're going to start distributing big boluses of money starting tomorrow. So you want to reserve your place in line because the last thing you want is for that money to go away and dry up and you not have had the opportunity to do that. For the first round of money that we got before, you have to go to a different website link, that's covid19.linkhealth.com, and complete the 4 steps to attest to that money. And as I mentioned before, please do that. Even though a lot of people didn't ask for that money and it just randomly showed up as a grant, there is a possibility that they could come back and pull it back if you didn't complete those 4 steps. So I think it's important to go ahead and do that. And honestly, to do those 4 steps is so easy. Each of the steps is only either clicking yes or no 1 or 2 times, or inputting just like your employee tax ID information and just some minor things. It probably takes about 3 or 4 minutes to complete as long as you know what you're doing. So reopening guidance, right? And like how to reopen and be safe. And Dr. Manchikanti talked about Kentucky, but you got to think about your own state. And the reason why I'm telling you this is this has business implications on your practice, because the last thing you want is for someone to come in and shut you down, or the Department of Health to come in and shut you down. In Ohio, they're saying if you have no mask, you can do no work and offer no services. You don't have to provide the mask to your customers, but you have to make it a policy that they do wear a mask. So, you can tell patients to bring their own mask in. Of course, this is unique to Ohio, and every state is different. I'm just using this as an example. They're telling you to conduct daily health assessments of fever and temperature, asking you to maintain good hygiene as far as hand washing, and to clean and sanitize contact surfaces, and of course limit capacity for social distances. One other thing I want to mention about Ohio, because this may happen in other states, is if you break the rules, like let's say you let patients in without a mask, or you don't make it a policy and you don't enforce. In Ohio, they're saying that they've created an anonymous tip line to whistleblow. And they're encouraging people to fill out anonymous tips so the Department of Health or other areas can come in and look at those businesses that aren't following the rules, and you don't want to be on that side of the equation. The other thing that happens to businesses is, to work with your health department or community if you do have confirmed cases to help with contact tracing. They're recommending to shut down the floor or area for deep sanitation if you know someone has trafficked that area and they test positive for it. And then, of course, if you have widespread infections that you have to shut down, you would have to reopen in consultation with your local health department. So in addition to the toolkit that you see that ASIPP made, with the risk stratification, we also are working on a checklist for procedure suites and ambulatory surgery centers. And I know that's really hard to read. I just have it up there as an example. It's basically a yes or no checklist that we're working on. And it's different things like, do you have a policy for social distancing? Do you encourage hand washing? Do you do assessments on people that come in. Do you require people to wear masks? Do you have enough PPE? Is your equipment functioning properly? Are any of your meds expired? Does your RFA machine work? Does your C-arm turn on? You know, all these things are actually on there, and they're geared towards the interventional pain physician. And the reason why I created this, or why we created this, let's say, is that, you know, if you go through that and you do the checklist, it might help jog your memory to make sure that you've covered all the bases if you have been closed for a while, to help you reopen properly, but also it provides you some defense. So if, say, the Department of Health came in and said, you know, what precautions did you take, you know, for your business? You say, you know what, we went through a whole algorithm and a whole list to make sure that we were ready, and we used this checklist right here, and here it is, and you can demonstrate all the stuff that you did, and I think that could provide you some defense. You know, of course, you still have to follow the rule of law, but making a good faith effort and documenting that you have made good faith efforts only helps you, you know, as long as you take action on things that are missing. So this is something that you'll see as another resource that ASIPP is providing for you. So the important thing is to remember to remain fiscally and financially disciplined, right? Some of you got the PPP loans, others did not. That money is starting to dry up too. So if you haven't heard yet, you still have a chance to get it with the second round of funding. Your chances are starting to diminish as the days go by if you haven't already gotten an E-Tran number. Although they really didn't start funding a lot of these loans until, you know, the early part of the week. So there's still an opportunity to get it. So just be vigilant in making sure you check with your bank. But the problem is that we're really going to start to feel it now in May and June for the lost claims from March and April. You know, like I said, 4 to 6 weeks to really notice the pinch. So right now you may be feeling that things are okay, or you have enough money in the bank, or the stimulus money is keeping you afloat. But come next month or the month after, it's really going to start to be painful because you're going to have expenses for running your practice because you're reopened, and you're going to be paying staff, and you're going to buy equipment, and you're paying for supplies, and you have all of that overhead to cover. But the actual money coming in is going to drop significantly for about 1 to 2 months until it recovers because of the lost claims that you had for March and April. So please keep that in mind as you plan your financial plan for yourself and for your practice, and you know, whether, and this applies to everyone, right? Whether you own your own business, whether you work for somebody, or whether you have, you know, or work for a very large institution, that you have to maintain financial discipline. And so now we'll move on to the open forum discussion. The moderators are Dr. Manchikanti and Dr. Devi and myself. And so I will turn the floor back over to Dr. Manchikanti to kick that off.
Thank you, Amol. The first question is, does PPE need to be changed for every patient? I would like Devi to answer this because New York is in tough shape, so she knows all the answers there.
Well, I don't know if I have the right answer, but I can tell you, you know, for us, it's very difficult to get a hold of anything. It's just what we already had in storage, sort of in the, you know, in the office. So I've ordered just regular surgical masks. I can't foresee us getting N95 masks here in New York. And then my plan with that, I mean, we use gloves and all of that stuff, but I'd probably use the same mask. And then we just don't have surgical gowns because our office is an in-office procedure suite, not necessarily a surgery center. So for us, we would be reusing them for the day at least, but unless they were dirty. But I don't know if that would be the same in a hospital or another setting where there might be plenty of PPE.
I know an oncologist in Louisville. He said he's carried this one mask for 7 days, and after that he was working without a mask. So,
yeah. I mean, that's the problem if you don't have it. Yeah.
Anybody else have any comment on that? Shalini or Amol? Harold? Okay, we'll move on.
I don't think anybody has the resource. I don't think anybody has the resources to change them after every patient. Certainly, you know, we're not taking care of high-risk patients that are positive for COVID and doing respiratory procedures on them. So certainly, you know, if they get worn out or stained or ripped, obviously you have to change them. But you can at least changing them every day would be the least you could do.
Okay, Howard, this question is for you. Harold, sorry. Is there guidance on protocol for staff that refuse testing?
I don't think there's guidance and protocol, but if that's what your policy is in your facility, that that you're going to screen your employees and they refuse it, I guess then you're going to have to make a decision whether you let that person back to work or not. If they don't want to get tested, then just the very least you would do is put them in quarantine for 14 days and let them return at that time.
Well, there are no policies. The CDC recommends that all personnel should be evaluated and tested and retested. So,
yeah. I was going to say in New York, we still have a shortage of tests. It's not that easy to get a test, either one, whether it's the antibody test or whether it's the test for the virus. So different states may have different protocols, but I think, for us as we plan to reopen it, we'll probably just check for symptoms, have the employees check off something, at least that they don't have symptoms, maybe record their temperature and stuff. But we can't make them have testing because, it's not possible to get the test easily. And even for us to order the test, we're not able to get them. So,
So the question is, actually, this happened to us here. First, we bought the antibody testing at one facility. We administered to everyone. Nobody objected to that. But in our facility in Paducah, they're offering the test now, nasal test. I went and took it myself yesterday, and you just register and go there. So I attempted to send all my employees there. So one employee did not want to have tests based on his religious beliefs. So that was the question comes from there. So now we are implementing that policy on all employees who are exposed with the patients in patient care areas. And this person is a transporter, so that could be, we don't know yet. He does not have any symptoms. He's a wonderful guy, very good employee, but that is his religious belief. So like Jehovah's Witness, they don't want the blood transfusion, but we're not forcing that on them when we do surgery. That was the first thing I learned when I came from India here. They don't take blood transfusions. So I guess the answers will be evolving slowly. Okay, next question is, when would screening mammograms procedures would be allowed? Which phase? This is for Amit. Probably he's the right person to answer that, expert. Amit?
Mammograms?
Yes.
Was the question, when was mammogram?
Yeah,
restart?
When would screening mammograms procedures would be allowed? Which phase? Is that phase one,
I think
phase two?
It should start. No, it probably should start off with phase 2. Although there is some close contact, but I think as we get comfortable, I would think end in phase 2, end of phase 2 in a few months. I don't think in weeks it's starting anyway soon. So I would think at least 2 to 3 months.
Okay. The next question is, COVID testing is not freely available in Missouri. If patient is asymptomatic, testing is not being done, what should we do in such situations? We need to really negotiate with your Department of Health and ask them to change what it is. I have not looked at Missouri regulation. You can send me an email. I will look at it, and then you can talk to them and ask them to change the policy where they will follow the CMS policy or something which says that you follow your society's guidelines. That way, you will be able to proceed with that. That is what we are doing in some of the states. And you also have a state society of Missouri interventional pain physicians. They can help you with that too. We can do that collaboratively. You can email me. I can look into that. Any other answers, Amol or Shalini?
Yeah, I have nothing else other than what you said. I think we'd have to look at it individually and understand the scope of the problem.
Okay. The next question is, how are we supposed to use face shields, gowns, N95s, and other PPE when we cannot get them? Right now, that is an issue, but pretty soon it's going to be a cost issue too. We can't afford them. In any case, you can answer, but I just got an email from one of my very good friends. He says his sister represents a firm that can get N95s and shields, PPE, etc. So if you guys send me an email if you are in need of that, I will send you her address and contact, etc. Thank you. Go ahead, whoever wants to answer.
ASIPP has a contact for N95 masks, and if anybody needs some, you can contact Harold Cordner, and we can get you some N95 masks at cost. They're right now about $3 to $4 a piece. So if you need some, contact me and we can get some to you.
Wow, that is awfully expensive, but they are at least available. So, any other comments? The next question is to Ian. Does Anesthesia Dynamics recommend we should get 115% of our current fee schedule during pandemic? When would it go back to 100%?
That's a great question. If we use, Medicare's increase as a guidance in a request, there would also be, as in your individual states, as far as the guidance of how long you would need to maintain through phase 1 or phase 2 or however long this goes on, the additional costs that you're taking onto your practice. The request that we've put out to the end of 2020. Now, not to say that wouldn't continue past that, but at least for the foreseeable future, from all of the information we've gathered, that the additional precautions would have to be in place at least through the end of 2020. And as your state opens up and gives guidance to that, there may be information in your guidance as well as what has been shared here today as far as the different types of costs that you're going to incur, from labor to additional supplies, as well as the time frames that these may be required. But it at least put the request out for the remainder of 2020.
Okay, there is another question for you. What do you mean asking the insurance company for more money, taking Medicare as a model? Can you please clarify this?
Sure. I would refer to the contracts that you have with the insurer, that there is some provision in there as far as making a change and how that has to be delivered, and how much time has to be provided for comment. So refer to your contract, but within your contract there is some area referring to, force majeure or acts of God, and essentially, refer to those sections on, in your letter or your request, but take time to detail out all the additional costs that you're taking on. And I wouldn't make it so much a request, but a demand. I would put it as a demand to the insurer, during these times, because they're certainly, taking advantage of the additional time that they're going to be provided in processing your claims.
Okay.
I want to. I'd like to comment too. Hi, this is Amol, everyone. I totally agree with trying the force majeure thing. I haven't done that, but what I have done, because I have so much free time now not seeing patients, is I have looked at my insurance contracts and done something that I was successful with that I want to share with all of you guys. As you know, there are new codes that came out for genicular nerve radiofrequency ablation and sacroiliac joint RF ablation. Now, at least in Ohio, the private insurances weren't covering those Medicare was, but the private insurances wasn't. So I went to each of my carriers and actually told them, hey, this new CPT code is out there. This is the Medicare fee schedule. Can we work something out for these codes? And actually every single one that I contacted, which for me was the big ones were Anthem, United, Medical Mutual, Cigna, and Humana, actually now have addendums in my contract to do those procedures. So something to think about, because that's low-lying fruit, right? Those there's so much data out there that those are accepted codes. There's an accepted fee schedule out there. There's a lot of clinical evidence behind those. So if you want to do those in your surgery center or offices and you don't have good relationships for those codes with those payers, just take the time to do that now if you have time, because I know a lot of us are about to reopen, but that was really helpful for me right now.
That's great. You need to give me that information. I had to start talking then. There is another question for you. Can you able to give advice on steps to get qualified for PPP forgiveness? It is a very difficult issue and it keeps changing. The banker who loaned us the money was telling me something changed today. So it is a fluid situation. So go ahead, please answer.
Yes, sure. I'd love to comment, and I think Harold may have some comments after me, possibly, on the same issue. Now, as you guys know, the way the PPP worked is that the banks didn't actually, even though they're the ones loaning the money came from the government to the bank to loan. So the bank is essentially controlling the loan for you. So when you ask for forgiveness, you actually are working with your bank directly. In other words, you won't be working with the SBA. That would be different than the SBA disaster loan, just so we know. So we're talking about the PPP here. You do have to supply a written request, and it has to be within 60 days or so, I believe, of receiving the money. Now, all of these things have changed so much over the past couple of days, so I apologize if I'm not exactly accurate on the dates. But what you need to know is that it is forgiven as long as 75% of it is used on payroll. And remember, PPP stands for Payroll, Protection Program, right? So the paycheck itself. So that is the key component as far as getting it forgivable. So you want to make sure that you have at least the same number of headcounts of employees that you had. You don't have to exactly have the same employees themselves, but as far as numbers of employees from when you started to when you finished, as far as your 8-week reporting period, that would help you. And the total amount of payroll is very important. And you can only use 75% of that. You have to use at least 75% of your forgivability on payroll itself. So if you want to use it for utilities, rent, mortgage interest, health insurance benefits, et cetera, that can only be 25% of your forgivability. So the important thing is to maintain documentation. And what I've heard other people do that I think has been very intelligent is that when they got their PPP money deposited, they actually put it into a separate bank account. They transferred that money into a separate bank account. That way they could very easily track the ins and outs of that money. You don't have to do that. If you have a good accounting and good documentation, you can do it. But anyway, really. But if you have it in a separate bank account, it becomes tremendously easier as far as saying, okay, this is what came in, and this is exactly what went out, and this is where it went, and then keep all of your receipts. And then you would submit that information to the bank, and the bank is ultimately responsible for making that decision about whether or not it's forgivable or not. Now, they do have to follow the rule of law. And I can tell you, the optics of them messing around or doing something sinister to you for the bank itself is going to be very difficult for them to overcome. So the odds are somewhat in your favor to that extent. That's not to say that bankers are trustworthy people. I mean, obviously, if they see an opportunity to make money, they're going to take it. So just make sure from your end you're following the rule of law as you ask for forgiveness. I would encourage doing frequent Google and internet searches because it may give you some ideas and tips on how to do that. And obviously, if you know people at your bank, to discuss with them. Harold, do you have anything else to add on top of that?
No, that was pretty good advice. The simple stuff is out there. Like you talked about it, most of the banks are actually suggesting that you open up a separate account for that because it's going to make the accounting easier for them and for you at the end. So that's really good advice. But there are a lot of details that are not visible when you first look at these things. There's a lot of details on that forgiveness thing. It's certainly too much to discuss now, but we may be able to consider doing that at another webinar to go through the details of that, because like I always say, the devil's in the details. So you covered it, most of it pretty well as far as the generalities of it. So that's as good as I can answer it with this short a time.
Thank you. The confusion starts at two levels. It says 80% of the payroll. You have to maintain 80% of the payroll. It says 8 weeks, and that essentially was translated into May and June. At the end of the June, you still should be paying from that money. That creates really major confusion because some of us got the money in April. So that makes 2.5 months or even a little longer than that. So if you don't have enough money to last 2.5 months, then I don't know then what happens. But they are saying it is a must that you have to maintain your payroll at end of June at 80% of what it was when you applied for that 1 month calculation. So there are like one issue and billion problems. The next question is, what about gown? Do you change per patient or continue wear it for the day? How long do you wait in between injection patients in an office setting? Shalini?
Sure. So you must wear contact and droplet precautions if your patient is known COVID positive. But if your patient is not COVID positive, or it's not known, or it's not symptomatic, then you don't need to wear a gown. The recommendation, if you have the ability to change your gown in between patients, obviously that's recommended, and that would be ideal. But in the event that you don't, and you know your COVID status is negative, you should be fine.
Okay, another question for you is there any literature that would suggest a lower dose of steroid is safer than a normal dose?
That's a very good question. We really tried to find as much literature evidence on this to find, does lower dose of steroid give as much efficacy as higher dose of steroid? And that we did find. That's why we recommended using lowest therapeutic effective dose on our risk stratification document. But sometimes some patients may not respond at the lower doses. So we didn't make that a outright recommendation. The second question as a follow-up that I think most people will be thinking about is, does steroid lower your immunogenicity, particularly for pain procedures? And that, again, was equivocal data, so we couldn't comment either way. But lowest effective steroid dose is what's recommended in your patients.
My impression is that whether you use a lower dose, I'm talking about like 20 milligrams of triamcinolone or 20 milligrams of depomedrol compared to 40 milligrams, their duration of adrenal suppression is less with the lower dose, but the intensity of the adrenal suppression is the same with lower dose and higher dose. So your immunogenicity is dependent on adrenal suppression. So it could be argued that there is no benefit using lower dose. Comment? Okay. The next question is, there was just a study that just came out of Wuhan from a group of physician scientists which stated that viral shedding is persistent even up to 21 days from onset of symptoms. Can you please comment on that and its implications on doing procedures and seeing patients in clinic? Devi, would you comment? You answered this question a billion times.
Sure. So there are a couple studies that showed that they don't know if the virus was active or not. So it could have been inactivated, which means that the person, if you have a patient, I think, that has had symptoms, clearly was sick, and then recovered, and you look at the time period that maybe that was at least 2 weeks ago that they recovered, then even without the antibody test right now, people are presuming that this person had the virus and now is safe to go out and about. On the other hand, if the person, has symptoms and they might test positive for the the virus, even if they don't test positive. If they have symptoms, you might not want to have them come in at all or to do any kind of procedure on them. So I would say that's the tricky part in terms of ordering the test too, because if you order it on someone who's asymptomatic, who you wanted to do the procedure on and previously was sick like a month ago, you may prefer, if you can get it, to do the antibody test rather than the actual COVID test, because if they test positive, it'll be tricky then trying to argue that you're ignoring the results of the test and you think it's safe to proceed.
Thank you. Any other? Shalini, you want to comment on that?
Yeah, I mean, if you think about it, again, it's a case series or just a population study. But if you think about it, that they're febrile and they're shedding for 21 days, you would see that symptomatically within 14 days. So, you know, whether it's 21 or 14 days, if your patient is symptomatic, it would still be, you know, you could still detect it. So I don't think it's going to change too much. For us. If they're febrile, you know, we're going to delay the procedure at this point for further testing.
This is
Dr. Manchikanti, this is Amit.
Yeah, go ahead, please. Sorry.
The one more thing to consider is, you know, even though the PCR may be positive, the person may not really be infectious. The infectiousness depends upon how much the viral load is in a particular patient. So there was a study quoted in New York Times in which they said the virus had to be 10 raised to the power 5 per ml for it to be infectious. So it's not like just one viral particle is going to infect. So even though the PCR may be positive, which may be telling us that the patient is recovering, the patient may no longer be infectious. So there is no, as Devi and Shalini mentioned, that doing a repeat test would not really help. So it's better to just let them cool off and get better clinically and wait the appropriate amount of time and do the antibody test if you have to and do the procedure.
Thank you. The question is, the additional $20 billion in provider relief funding, is this distributed based on the year 2019 or 2018? It is 2019. The next question is, are we recommending all staff and providers be tested before starting procedure? Again, it depends on the state regulations, and majority of them are saying that they should be tested or at least monitored according to the federal regulations. Anybody would like to comment? This is from Illinois. So, Shalini?
No, you're exactly right. You got it. So it's one of the gating processes that was in place from the federal government was that adequate testing be available for staff and healthcare workers, and then states can reinforce that or make additional recommendations. So it's individually state-based.
Okay. Amit, would you like to comment on that?
No, I think, it has to be state-based, but I don't think testing by itself would help. Now are we going to test every day or every week? So that creates too many other. I think using overall precautions is more helpful than going around testing. Each test is expensive as well. I think it's at least $50 for the PCR test, and it'll be more, and also more around 100 or so for the serology test. So I don't know how much are we going to spend to just to get some comfort that we have or do not have the virus. But I think the best thing would be to use the precautions and make sure that the patient doesn't have the virus, and then proceed. Because we have to potentially think that everything around us is infectious and protect ourselves from it.
Well, as far as Illinois is concerned, I just was writing a letter to the department director and the governor. For ambulatory surgery centers and offices, it is a must. There is no other option. They're actually saying that all the patients have to have it done 72 hours before and quarantined and all that stuff. So there is no choice there. And in Kentucky, it is a recommendation. In Indiana, it is a recommendation. So as we said, each state is different, but if you have a state which is ruled by a Democratic governor and legislature or one or the other, their rules are much tougher and they just get on to you. Okay, the next question is, we want to do all these tests, but who will pay for the COVID-19 testing for patients, both nasopharynx and serology testing? So this is a major issue. All these patients, insurance companies are not going to approve anymore. They're already saying that premiums are going to be up 41%. Now, if they approve these tests, it is going to be much higher. So they are just going to advise that do telemedicine and treat them with medicines. Okay, Ian, that is your question. Who will pay for the COVID-19 testing? Are you thinking, or?
Sorry, I was trying to engage the microphone there. So it's again, this is something that would be important to reach out to your insurers, and bring this up as a point that if you're planning to test daily within 48 hours, 72 hours, whatever that time span may be, this is an important thing to point out, especially the testing on your staff, the costs associated with that. But I think it's a important point to reach out to the insurers at this point and find out what that policy is, or try to promote a policy as well as a fee schedule that associates with that. So it's I don't think there's one answer there I can give you that is going to close that question out. But this is one of those things, an important time to reach out to your insurer and present this issue and propose a solution.
Well, they're not going to reach out. We can reach out, but they're not going to touch us. They're really going to maintain social distancing now. Next question. How long should we expect insurance companies to pay for telehealth, at least to the end of year or beyond? Should ASIPP, AMA, etc. be working to keep those payments in place? Yes, sir, we are working and we are requesting them to up to August 6th. They haven't approved that, so it is going to be very difficult. Beyond that, I'm hoping that they will approve that, and we are working on it. Senator Cassidy, along with others, are trying to help us. We made several phone calls from senators and members of the Congress. Now, he is trying to help, so we have to look at it, and he's going to speak here next time. Then, next question is: are you doing emergent/urgent cases in your ASC now during safer at home period? Well, this is just everybody is doing something, and they're classifying them as urgent, emergent. Even it is all questionable. When they come and inquire, it becomes questionable. But if they are emergent, you can do them. If they are urgent, you can do them. Next, should you test employees with antibody test, antigen test, or both? Amit?
I think the first thing will be cost. Who's going to pay? I think that'll be like if in an ideal situation, yes, test them to make sure that if they're immune, then we're good. But if they're not immune, then we'll have to use. I think using overall infection control measures is the best. If it's a point of hiring, I think at that point you can potentially say that if you want to exclude people based upon their serologic test, that might be something for the future to think about if we keep on going for months like this. But again, who's going to pay for the serologic tests? I don't understand who's going to pay. So it would be best if we can do it somehow, but I think that's a big problem.
Does not pay again. We can't pay. We are all broke now. So then. And
I was just going to add with the antibody test. With the antibody test, the specificity is 93 to 100%. So if they have the antibodies, we don't know for sure if they'll be safe or not, but at least generally we can say hopefully they would have some immunity. But if they test negative for the antibody, it really doesn't tell you anything because, either they have never seen COVID before, or they may be positive for it, or they may have the antibodies, but they just don't test positive.
And also the tests are not so good right now. So I don't know whether we should rely on them to screen out like that. So I think we should wait a little bit to see how these tests pan out.
So there is a question on how long, minutes, hours, do you wait in between injection patients in an office setting? I think Shalini, Devi, and Amit, all of you can answer that question one by one.
Sure, I can go first. If you are performing in an ASC, like I said, it's depending on your setup, on your ACH, your air turnover per hour or air changes per hour. If you're in the office, that's really dependent on you. That your air changes and your flow is not going to make that much of a difference. So it always depends on what your capabilities are to wipe down surfaces and the procedure bed prior to bringing in the next patient.
There was a study done in Montana by the NIH that looked at how long does the virus stay in the air, and if there were aerosolized procedures, then it was about 2 hours. So the things that we're doing, generally, we shouldn't be producing a lot of aerosols, so it should be much shorter. And at least in New York, everybody's required to wear a mask now if they're going outside. So the patients already have masks; they have to legally, and then we have to wear masks as well in the office, not just in the procedure suite. So generally, it should be kind of containing all these droplets. We shouldn't be seeing the aerosols. So at least for our office, I probably would kind of stagger the patients so there's like at least a 15 to 20 minute period in between where then, like Shalini said, there's some air turnover. You have time to wipe down the surfaces, especially the doorknobs and stuff. And then also some patients tend to come early, some stay a little late, but at least to have some leeway where, you have enough space for them to kind of move around without coming too close to each other.
Okay, thank you. Amit?
No, I think I like Shalini's idea of using the time for air circulation, and that's reasonable. And I mean, if someone is negative, I think you can keep going. But if someone were to positive, then obviously we're not doing the procedure anyways. But giving a 15 to 20 minute time in between, as Devi mentions, I think is reasonable as well. I don't think I have anything much to add.
15 to 20 minutes between each patient. So after one patient leaves, then we have to wait another 15 minutes, even though we are not really contaminating, and these are all percutaneous contained procedures.
Yeah, I think so. I mean, for us, oh, sorry. I was going to say, I mean, for us, it's a little different. New York, the spaces are tighter also. So if we have, let's say the person, maybe they bring an escort or, who knows, but if they're taking up space in the waiting area and the other areas, we just don't want them to be pushed closer together. But I would say if you're in a place where you can keep everybody separate from each other, maybe then that period can be shortened.
Well, there was some.
How much time do you have between?
Okay, there are two questions related to, are there any observations or studies suggest that steroids have affected any COVID patient? Are we still basing our recommendations on historical concepts regarding steroids? Related question is that, are there any studies comparing short-acting dexamethasone versus the long-acting depot steroids? Shalini?
So the steroids is a difficult one to say because, and I'm assuming when they mean steroids, we're talking about interventional pain procedures. So during the COVID pandemic, obviously, very little procedures with steroids have been done. But interestingly, I just saw an article in which there is a consideration for a trial of using IV steroids during critically ill cases of COVID, which is, which is debatable in itself, and it seems to show to confer some immunity or some better outcomes than not using steroids. That's the only thing that I have seen thus far.
Okay. Then next question is, I thought that Trump said that the feds were going to pay for testing. Having said that, why not send your suspected patient to the hospital staging areas and let them bill the government and save yourself a headache? Very nice comment that I wish it worked all the time. That is what we are doing actually right now. So, anybody wants to comment on that?
Well, I can comment a little bit. In Florida, they have actually state-sponsored testing that is free, and they actually also have vans that are going around and buses that have portable labs in them going around to nursing homes and facilities. So there certainly are hospital-run, state-run facilities that are doing testing. Most of the insurance carriers also will cover testing without deductibles or copays. So yeah, it's certainly a good idea. If patients can get it done for free at a drive-up, to get it done. Why not?
Okay.
But don't you need a referral from a doctor to get the testing done?
Not
well, yeah, but if you're prescribing the patient to get tested before a procedure, you give them a prescription for it.
But they are doing them even without prescription now, so many places, I won't say all. On these regulations in Illinois, you need to go to the IDPD, I think that is the name of the department, but please send me an email. I will be happy to forward those documents. But it is specifically referring surgery centers and hospitals. I wrote to them and I have been trying to get the information on office procedures. I have not been able to get that information yet. COVID-19 patients have hypercoagulable states. What precautions should we take with regards to injections?
Can I answer that, Dr. M? Okay, so this question came up last time on the webinar as well. It's a great question. The important thing to realize about the hypercoagulable state is that it's not a presenting symptom. It's actually a late stage finding that occurs in the critically ill patients. So this is not a finding that you're going to find in your asymptomatic patients, nor are you going to find in your acutely symptomatic patients. This is a very late stage finding that occurs in those patients that have been intubated and are on very critical status.
Thank you. The next question is, if we are not going to wait a few hours between in-office procedures, then why wait 15 minutes? There isn't any data to suggest that waiting 15 minutes between procedures would be useful. Is there? Shalini and Devi? Shalini?
Sure. So, okay.
Go ahead, Devi.
Yeah, go ahead,
no, well, for me, I was thinking more about just space constraints and stuff. So for our office, if we have, sometimes there's fluctuations, people coming in early for appointments, sometimes people taking longer than expected, just the people taking some time to move around, and then the escort. So if we kind of halved what we were doing and made the appointment times kind of double the time, then at least there would be less chance that these people would be in close proximity to each other, either coming out from the procedure, coming into the procedure, or sitting together in the waiting area. So it's more just to kind of decrease the volume of people that would be in the office at any given time. But I mean, everything is a judgment call depending on sort of, where you might be. If there's something, like I said, there's a study about the 2 hours. If you're talking about aerosolized procedures here, that's not the case. But there is still some evidence that the droplets could be there on the surfaces. So if you need time to kind of clean that area as well, a little bit more so than you normally would, then maybe the 15 minutes would give you that. But that was just for our practice.
Well, that is the most important thing. You have practical experience. So, Shalini?
Yeah, I think Dr. Devi said it perfectly. I don't have much to add except for it's more about exactly a space constraint issue and not impacting your waiting rooms and your throughput and PACUs and things like that. So, we're talking phase one. If you have the flexibility to wait and only schedule 2 procedures an hour, that might be reasonable, depending on your facility. So it's, again, like Dr. Devi said, it's a judgment call.
Okay.
I just want to add one thing. It also depends on what disinfectant you're using on the surfaces. You should be using CDC recommended disinfectants that will be proven to kill the COVID virus. There's many of them out there that will not. And there's also surface time that disinfectant has to sit before it's been effective. Some of them may be 2 minutes, some of them may be 5 minutes. So make sure that you check what disinfectant you're using and that it's effective, been proven effective. And CDC has a list of those approved disinfectants, and that you follow the guidelines for how long it needs to sit before letting a patient in.
Okay, we have 2 more minutes. Last question. Since many COVID positive are asymptomatic, should we be testing all asymptomatic patients prior to doing procedures on them? That is what we are trying to avoid. Like in Illinois, that is what it says by law. Arkansas says the same thing. Every patient having a procedure, not even in the surgery center. In Illinois, that's so far my interpretation is surgery centers and hospitals. In Arkansas, everywhere, they all have to have the testing done. There is another question. I read otherwise about stroke as the presenting symptom for younger, 30 to 50s patients with COVID-19. Please comment. This is for Shalini. 1 minute.
I'll let Dr. Devi comment.
Okay.
So this has to do with the hypercoagulable state also. I mean, I've heard about it, but I haven't seen it myself, but that some people are presenting with these thromboembolic strokes and then later found to test positive for COVID-19, but I don't know if they were otherwise asymptomatic. It's just that some of these strokes are appearing in younger people, but it could be that they had the whole flurry of symptoms, but what actually sent them, to the ICU or to the OR was the stroke.
Okay, then. Thank you. Thank you all for wonderful webinar, and we'll see you again on next Tuesday. That will be the last webinar. Thank you again. Good night.
Okay, thank you.
Good night, everybody. Thank you.
Thank you.
Good audience members, that is all the time that we have for today. So on behalf of ASIPP, I'd like to thank you all for joining and for your participation. I'd like to call your attention to both the announcements box on the left side of your screen, as well as the banner message you should see at the top of your screen. In both of these places, you can request your CME request information. So you can request your CME credits by clicking on that link either in the banner or in the announcement section. You could fill out the brief survey as well that appears on your screen. That would be great. So it does help us for planning for future programs. Again, this does conclude today's presentation. At this time, you may now disconnect.